All right. So a little levity before we get to a really a topic that is near and dear to my heart. Hopefully this will not apply to many of you in the room. Just to kind of preface, to talk about transplant, I usually avoid survival curves and things like that because I feel like everybody's an individual. And so you have to look at it like what is going to happen to you. And when we look at the transplant data, so much of it is such a wide variance of people that it's really difficult to say, yes, this curve that we look at, survival curves, which are kind of depressing because, every time it goes down, it means somebody's died. This survival curve, is that really going to apply to you or not? So as we talk about this, I certainly don't have as much data-driven stuff, but I think it is really important to kind of understand what happens with a transplant, the process of transplant, what to expect when you go to a consultation, because these things are all very challenging. And I will throw in different areas where we have learned more about transplant, which has been great. But it again is a very difficult topic to put survival curves and everything to. So this is normally historically it's been done in two separate talks. It would be myself and then Dr. Deeg, but he retired, like many people do. And so I'm going to be kind of covering the full gamut of things. So when we first start, this is sort of setting the stage and understanding what is a bone marrow transplant. What do you need to be thinking about? Timing of transplant and understanding disease risk. So bone marrow transplant basically involves high or intermediate dose chemotherapy, followed by a hematopoietic stem cell infusion. And as we've learned from some of the other talks, hematopoietic stem cells are sort of the very beginning of all the cells in our marrow or whole blood system. Chemotherapy is part of it, and it helps reduce the disease. And the disease reduction part can be in a bunch of different levels. You can have really high dose, so you get lots of disease reduction. You can have low dose, where maybe you don't get as much disease reduction. But the most important part of the transplant is suppressing that immune system so that the new immune system can come in and won't be kicked back out, which is really important. We know that the new blood system will work better because if you need a transplant, you have a disease that is not very kind. And so the new blood system will actually grow better and grow healthy cells. But more importantly is that new immune system will go and attack any last bits of disease that are left behind. If anything, you've learned that cells for myeloproliferative diseases are incredibly resilient and strong and want to grow. And so they're very hard to get rid of, and some are going to be left behind, even if you use the highest doses of chemotherapy. So that new immune system is key. So you'll recall Dr. Nangalia showed that slide of the identical twins. And sometimes people come in and they're like, I have an identical twin. Will they be able to be my donor? And the answer is actually no, because identical twins will not recognize you as foreign. Therefore, you don't have that graft versus leukemia effect. I have done a transplant in somebody that was actually an auto transplant, which is where you use your own cells. And I did it with an identical twin, so they didn't have any disease left in there, but that was a very unique situation. So autologous transplants, many times people say, oh, I know this person, they did a transplant, they were like better in 100 days. It's probably an autologous stem cell transplant, which is very different because that's when people get chemotherapy and they get their own cells back. And when you get your own cells back, they grow a lot better, works a lot better for the purpose. And the main reason to do it is that you really want to give somebody high doses of chemotherapy that would have so much toxicity on the marrow that it wouldn't otherwise grow back. That's a completely separate thing than you need for myelofibrosis. With myelofibrosis, you do not want your own cells back. You want to get somebody else's cells because your bone marrow cells don't work right. And so allogeneic transplant is the one. So the other thing that comes up frequently is, okay, well, there's peripheral blood stem cell transplant, hematopoietic stem cell transplant, and bone marrow transplant. What's the difference? They're all the same thing. You have bone marrow stem cells in your bone marrow. You need to take them out. You need to put them into a new person. Now, if we collect them through peripheral blood, it means we give a shot. The shot makes the blood, peripheral blood come out the stem cells come out into the peripheral blood, and we can collect them, just like kind of almost through dialysis type of thing. Bone marrow basically means the person goes to the OR, and you saw the description of a bone marrow biopsy. Well, we do that about 50 or 60 times per side. So you have two people in there. The person's, general anesthesia. They're laid prone, and we sit there, and I've done many of these where you're just sitting there and drilling and drilling and drilling. Hematopoietic stem cell transplant basically covers both. So when we look at leukapheresis, this is just a nice picture of leukapheresis. You have somebody, and sometimes they can do it out of the arm, sometimes there's a line in the neck. Basically pull the blood out, spin it around, all the white blood cells, which will have the stem cells, come out on one side, and then the rest of the blood goes back into the person. So it's almost like a filtering type of process. And at the end of it, you end up with this bag of stem cells that's really anticlimactic. It looks like a bag of blood. And so, we do stem cell blessings and stuff. We have a chaplain who does a really wonderful job blessing people's stem cells before they get them. But the process, how it goes, is there's a donor. The donor's collected. It's processed. Ends up in a bag like that. Sometimes we freeze it, and sometimes we don't. It doesn't matter if they're frozen or not. We were freezing them all during COVID, but now we try to do more fresh stem cell collections. The patient, meanwhile, is getting chemotherapy, and then after they get the chemotherapy, usually get a day of rest to let the chemo kind of get out of the system, and then they get their stem cells. And that's it, and it's like takes a couple hours. So it's a huge deal. I mean, that somebody, half the time, or over half the time, it's a stranger, has taken the time out of their life to donate some of their stem cells. We know it is a safe procedure. That's something that often gets asked is, what does this mean for the donor? It's a very safe procedure. We've been using unrelated donors for 30 to 40 years. So there's been a number of studies done to look at donor safety because, we don't want volunteer donors to lose anything. So that is what we do. So, I'm just talking about chemotherapy and hospitalizations and all these stem cells and everything. So you might say, well, why do I want to do this to myself? Should I pursue a clinical? And if you've had a meeting with me, which many of you have, and some for transplant, hopefully you did leave that meeting saying, why do I want to do this to myself? Because if I don't leave you scared, then I haven't done my job right. So the next question, should you pursue a clinical trial? Well, that is a very personal preference, and it's not one that I have an easy answer to. So what are concerns about transplant? We actually did a survey a while back on patients with MPN and found that less than half of them were referred to transplant. And this is like trying to select pretty much for people who had myelofibrosis. So less than half were referred to a transplant. Of those who saw a transplant specialist, less than half were planning on having a transplant. And people were worried about quality of life. That's a huge one. Financial implications. It's not cheap. Because even if you have great insurance, there's still co-pays. You take time off of work. Your caregiver may have to take time off of work. And then graft versus host disease, which we'll talk about in a little bit. It was an unfortunate thing because there's probably a lot of people out there who, before they even get through my office, into my office, are saying, I don't want to do this. And a lot of doctors, I think, who maybe aren't as familiar with it, when they talk to a patient about transplant, the nonverbal communication's there. I mean, none of us can avoid projecting our thoughts, even if we don't say them. And so I think that there are a lot of people. Now, I think as we've gone on, even over the time frame that I've been doing transplants, focusing on myelofibrosis, more and more people are coming. And I think there's more education about it, which is great. But that is something that's known. So there are good clinical trials and treatments, and as you see, I mean, we're coming up with all sorts of fabulous things, like the calreticulin mutation-directed therapy, and there's a mutated JAK2-directed therapy. So I think there are things that are changing, but there's no curative options as of yet. And again, as I said, this is a really individualized decision. So when should you see a transplant specialist? You should see them before you need a transplant. Obviously, you shouldn't, like somebody who has ET shouldn't come to a transplant specialist saying, well, I might have myelofibrosis and then I might need a transplant. But if you've been diagnosed with myelofibrosis and, you're usually our kind of upper limit for transplants, usually around 75. So if you anticipate it would happen at some point around then and it's something, go get an opinion. It doesn't mean you have to do transplant. It doesn't mean you even have to do any of the steps towards it. But it's very important to hear about transplant from a transplanter, and probably hear about it before you come up with all sorts of preconceived notions about what it involves, because you can go look online and either terrify yourself or make it out to seem like it's not going to be that bad, and it's somewhere in the middle. Understanding the resource needs for a transplant is really important. You need a caregiver. So the first 100 days after a transplant, every center says you have to have somebody with you 24/7. And I mean, granted, they can run to the grocery store maybe, but the caregiver piece is important. You will not get a transplant without a caregiver. The financial component of it, co-pays. There's a lot of super expensive drugs. Sometimes you have to live away from home. You have to live near a transplant center. So all of that takes a lot of coordination. Now, we're used to doing this. Our staff are great at helping people coordinate, but it is something that's really important to know. Understand the process of transplants, just really understanding what it's all about and hearing about it. And then this gives you time to process all of the information. I mean, usually when I have people leave my office, they go out with a book. And this book has everything you could possibly want to know about transplant. So I tell people, I said, well, read it, and when you start to get overwhelmed, close it and put it in the closet for a while. You know, you have to digest it in pieces. If you try to read the whole thing, you'll be terrified. And the other thing to keep in mind about this is it's a marathon. And I don't know if any of you are long-distance runners or bikers or anything. If you're doing a marathon or a century ride, as it were, for cyclists, at mile 20, if you're thinking about mile 80, you are done. I mean, you're mentally going to do yourself in. So you really have to be focusing on the day at a time and not thinking about the whole process. So it's really helpful to see somebody who specializes in MPN and transplant, and there's some increasing numbers of us around. You don't have to necessarily get your transplant there, so if your transplant center maybe doesn't have that type of person, just going to see them and getting the opinion can be very helpful. As a transplanter, before I became an MPN person, you know, you see things differently when you really understand myelofibrosis and the timing and what it involves versus, you know, transplanter is a lot more black and white. The timing of transplant is very much a shared decision-making process. My goal is to make sure whoever I'm talking to is educated enough to be able to make the decision that's going to work best for them. And not one answer is correct for anybody. I have some people who say, I don't want a transplant. And I don't do a transplant, and they, even when they're 3 or 4 years later or 5 years later, whatever it is, if they're not doing well, they're like, I'm still glad I didn't do a transplant. So it is a very, very individualized decision. There's no right or wrong. So what to expect? Okay, first of all, bring someone with you. Do not go to this meeting by yourself. There's a lot of information given, and you really want to have 2 sets of ears. That's super important. It's scary. I don't make people cry as much as I used to, but I used to think that if somebody doesn't cry, I haven't done my job. If you can, record the consultation. So much information is given. The majority of us don't mind being recorded, as long as I don't have to listen to it. But it is something that can be good. And then if you have any doubts, get another opinion. Like, I help facilitate people getting second opinions. I mean, this is a procedure that can go very, very well, but it can also go very, very wrong. And if it goes wrong, you want to feel 100% sure that you made the right decision for yourself. So when should you get a transplant? Well, generally it's reserved for higher risk patients, but that bar of higher risk patients has been moving quite a bit. So one thing that's really important is to know your risk, to understand risk, and also understand the limitations of the way we identify risk. And sometimes it's dependent on life events. I mean, if you've, you know, a daughter who's going to get married in a year, or you have something else happening. I mean, I've delayed transplants for some of these things, for those big life events, because they are important. And fortunately, transplant for myelofibrosis rarely is one that needs to be a specific time. If you have acute myeloid leukemia, it's a different story. I don't let people delay. But with myelofibrosis, you want to make sure if you don't have that buffer of a window, you know, then it's a different situation. So usually we have some of a buffer, but it's not an absolute thing to have that buffer time. So how do we define risk? So this has been brought up in a couple of the other discussions, but first there's the IPSS, which I didn't include in this, and there's the DIPSS. And so this one generates scores based on a set of risk factors. So based on anemia. Anemia is a big one. White blood cell count, blast percentage, constitutional symptoms, and age greater than 60, or 65, I think it actually is. And then there's the DIPS plus, which also includes if your platelets are less than 100, if you're transfusion dependent, or if you have poor risk cytogenetics. Now you'll note I did not put survival times here. The reason being, this score was generated before we even had ruxolitinib. Both of these publications came out before that. Ruxolitinib has changed the face of myelofibrosis. So I feel like if we use those survival times, sometimes it can be a little bit overwhelming. The other thing is a lot of times these survival times will say, oh, this is, you know, the survival time here is 3 years or 7 years. But if you actually look at the range, the average range is from like 3 years to 12 years. So you have to remember when they give survival times, and if you look it up, because, you know, of course, everyone has access to all this stuff, which is great, but you also have to understand what they're actually saying when they say that survival time. It's not like the clock is ticking and, oh, I got 7 years, I better live my life. There's a range. Some people are shorter, some people are longer, and many times that range is quite long. So we know that anemia is a hemoglobin of less than 10. So if you're 11.5, you generally will not be in that situation. And I'm sorry, I think that's my pager over there. I don't know why somebody's paging me today. There's thrombocytopenia, that's platelets of less than 100. Leukocytosis is a white blood cell count greater than 25. The upper limit of normal is 10. So, the leukocytosis is greater than that. And then the blasts. Blasts are immature white blood cells. They're the very beginning of it all. All of us have blasts. All of us have 1 to 2% blasts. Remember that, because people look at their marrow report and we talk about blasts and they're like, oh my God, there's blasts in my marrow. But blasts are normal. We see them. We all have them. If you did a marrow me, I have blasts. Now, the blast percentage is generally referring to the peripheral blood, so the blood I draw out of the arm, not necessarily the bone marrow. We do know that if they get greater than 20%, they're defined as acute leukemia. We don't like it when they are increasing in number, but to see 1 or 2% blasts is not unheard of in myelofibrosis because, as you've seen, there's a lot of scar tissue. So all that beautiful, natural, nurturing environment the bone marrow is supposed to provide doesn't work right. So everything gets popped out into the peripheral blood a lot earlier. And then abnormal karyotype. Sometimes it's hard to get this because when you do an aspirate, which is the part where you pull out the liquid portion of the marrow, on somebody with myelofibrosis, sometimes it's so scarred that you can't actually get a good aspirate. So many people don't have karyotype, and that's those X's that have been shown in, I think, some of the other presentations. And then constitutional symptoms. So fatigue is really common and very multifactorial. It's hard to fix that, but especially when I start to see weight loss, decreased appetite, night sweats, those are things that are really more concerning to me. So there is a stem cell transplant timing tool that probably is a little bit antiquated now. This uses basically the DIPSS type scoring system. And I think even though I don't necessarily agree with the estimated survival times as much, I do think all these factors that are defined as risk are very important. So when we start to calculate these risks, I think they hold true. I just don't use survival times attached to them. So if you think about the time frame of this disease, you get diagnosed with the disease. This is kind of when you're lower risk, and then intermediate risk and high risk with organ dysfunction. You really should be thinking about transplant pretty early on. I mean, sometimes people are diagnosed with intermediate 2 risk or high risk disease, in which case you're thinking about it and you may actually have to go forward with it. But if you get diagnosed with low risk or especially intermediate 1 risk disease, it's really important to think about this. When you want to do a transplant is somewhere around DIPSS intermediate 2, but it may be a little earlier than that in some patients. So what other factors contribute to risk? There's driver mutation, which is the JAK2, the calreticulin MPL. There's cytogenetics, and then there's molecular mutations. So we all talked about driver mutations. There's JAK2, MPL, CalR. CalR is good. If you don't have any mutations, it's considered triple negative, and that tends to be a more aggressive disease. Cytogenetics, again, are the X's and Y's. And there are certain mutations that we know carry somewhat of a higher risk, or if you have a bunch of them, that's also not good. So the next generation sequencing, and you guys have heard a lot about molecular stuff, so I don't need to belabor this point. But we have these panels, and I think the panel at Mayo is 42. There's some panels that are 248. There's some panels that are 500. I mean, we can look at genes out the wazoo, but there are certain ones that really seem to be implicated in disease outcome. And for primary myelofibrosis, it's the genes there. And again, it's kind of alphabet soup, so you don't necessarily need to remember each one. But these gene mutations can be extremely helpful when talking to somebody to say, what does your disease risk look like? And so that might actually, say, well, geez, if somebody has bad risk mutations, sometimes first of all, I say, the minute you get to that point where you need a transplant defined by DIPSS, you should get one. And a lot of times I'll actually do it earlier than that. Now, then it gets tricky of what point, if somebody has completely normal blood counts, do you say, okay, guess what, we're going to get a transplant when you have everything looks completely normal in your blood? I don't know that that's 100% necessary. Again, this is something this is a discussion that needs to be had just to kind of understand what the risks of waiting are and what the risks of moving forward are. And something that is a really hard decision to make, and I wish we had better options of different things to be able to tell people, but it does kind of it's a bit of a gamble of sorts. So other considerations, symptom burden. If somebody's having a lot of symptoms, they're not controlled by JAK inhibitors. That's something that indicates more the disease isn't responding well. Is somebody on ruxolitinib? How are they responding to it? or have they progressed through it? We do know that progressing through a JAK inhibitor generally conveys a worse prognosis. So even if somebody maybe doesn't have a lot of super alarming factors, if they've clearly progressed through ruxolitinib, that is something that would make me think of a transplant. Transfusion dependence. If somebody needs red blood cell transfusions, that's actually one of the situations where I usually say, I really think you should get a transplant, because that is an independently a poor prognostic factor. And then you have to try to look at what gives you these points on all these scoring systems. So example. Now, the other thing to keep in mind, and this is a good sort of explanation of it, is so you have a 64-year-old CALR positive, and then one day they have 23 white blood cells, 2% blasts, a low hemoglobin that's less than 10, and their DIPSS score is 3. A month later, their white blood cell count might be higher, their blast percentage may be lower, their hemoglobin might be above 10. So you can really have a lot of variation in the DIP score from day to day. So you have to take that all with a grain of salt. So I always tell patients, I monitor people's blood work once a month, much to the dismay of my nurse, who usually has to help keep track of that. But the thing is any one blood test is not going to make or break what's going to happen. You always want to get a trend, because there can always be an aberrant blood test for whatever reason, and we all fluctuate. I mean, if you took my blood, the same tube, and ran it maybe 3 or 4 hours apart, it could potentially be different. So there is a degree of variation with this. It's important to understand. I'll skip the other 2 ones because we still have a lot to talk about. So one thing is, if I feel so good on Jakafi, should I really proceed with transplant? And that's a tough one. I mean, you give somebody Jakafi, it can be a game changer. People can feel so much better on it. Well, you don't want to wait till you've lost your response to Jakafi, because then you've probably gone too long. When people are having a favorable response to Jakafi, that's actually a good time to go to transplant, because we've managed to quiet down a lot of that inflammation. And we do think that if the spleen is smaller, the inflammation has calmed down, we may see better outcomes. So what about these newer agents that may reduce the fibrosis, or may reduce the clonal burden or something? Should you do that first? And right now we don't really have evidence to support or deny it. I mean, I suspect at some point, I'm very hopeful that we come up with things that make a tangible difference that can be defined, and we can say, yes, this helps us in transplant timing. Right now, I think that it's more of a philosophical question of whether you do a clinical trial versus transplant. I think clinical trials are wonderful, but transplant's also something that is timely. So that becomes a personalized decision, and it's not one that I can make for people. So what happens with the transplant? So the transplant itself. So there's a couple of things you really want to know pretty far ahead of time. Number one, you'll be seen daily for a month. Some places do it in the hospital, sometimes it's out of the hospital. But you want to make sure you clarify that. For better or for worse, sometimes people prefer to be in the hospital because they know they have nursing staff right there and they have everyone watching them. Sometimes people say, I'd much rather be at home. And there's ways to do both of them, and this is a constantly moving target. Now we have things like remote patient monitoring, where you can have a nurse call you every 4 hours and check vitals. So there are ways of doing this, and it's very much center dependent. You have to live near the transplant center for 100 days. Every transplant center has a slightly different time frame. Ours is 60 minutes, some use 30 minutes. You need that full-time caregiver that I mentioned before. There are a lot of restrictions. Pretty much it's COVID all over again for everybody. Masks, avoiding people, no crowds, and you have to have your little group of people. And then sometimes you'll be off of work even up to a year, which is a really big deal. Part of the reason to understand about this early, so you can kind of plan life. So finding a donor. Now this is actually a kind of exciting area. Historically, and I think there's a lot of data that suggests that related donors are probably the best. And when we talk about donors, in the next couple slides, I'll explain that a little bit more. We know that matched unrelated donors probably are almost equivalent, but it's questionable. There's some studies that say that sibling donors are superior. There's other studies that say it may be, matched unrelated donor might be a little inferior, or they might be equal. So we don't really know. And then things change along the way that makes it even more difficult. And so, as I said, donors can be related or unrelated, and we'll talk about degrees of match. Just so you know, there's about 40 million potential bone marrow donors out there. So when we look at this unrelated donor pool, it's huge. The good part is it's huge, so there's lots of people out there willing to do this. The bad part is that if you don't have a good donor, you probably won't have one because we have such a wide variety of donors that if you're going to have a match, we generally would have it. Now, why you say, well, why wouldn't I have a match? And I'll go over that in just a minute. Just so you know, there's 3 of them. There's Be the Match, or the National Marrow Donor Program, which is based out of Minnesota. There's the DKMS, which does huge number of donations. I mean, it's fabulous. The German donors are the most reliable. That's over in Germany. And then there's the World Marrow Donor Association, which goes to a lot of other smaller things, like getting a donor from Israel or from Australia or someplace else. So when you talk about a donor, we talk about different matches. Sometimes we say 12 out of 12, 10 out of 10, 8 out of 8, 6 out of 6. What does that all mean? So on the 6th chromosome is where you find the HLA markers. And there's HLA A, B, and C. Those are all class 1. And then DR, DQ, and DP, and those are all class 2. Now, DP is a complicated one, and we don't generally count that. DQ, so then you get to the 10 out of 10. DQ is one that mostly is kept on for posterity's sake. It doesn't actually make that much of a difference. But we still use 10 out of 10, and for some reason everyone still says 10 out of 10, even though the DQ, if it's not matched, I don't mind that much. So then we look at 8 out of 8. Now these ones are all pretty important. So that's A, B, C, and DR. You get a set from mom, a set from dad. That's how you get 8. And we do, for each of the A, B, C, and DR, there's hundreds of different possibilities. So when you do the math, it's actually pretty amazing that we're able to find a donor for anybody. And so when people say, my next door neighbor really wants to be my donor, or my spouse wants to be my donor, the chances in that matching are 1 in a million for that reason. And then, sorry, this is going really fast. I'll try that way. They do use 6 out of 6 is usually only used for cord blood, and thankfully cord blood has not really required anymore because we have such a variety of donors we can use. So who are the potential donors? So you have a mom and a dad, as you can see, that because they're sort of color-coded up there. And then you might have siblings. Now each sibling, and yourself, you get one from mom, one from dad. So when you look at it, there's a 25% chance that you'll get the same 2 from mom and dad. There's a 50% chance, if they're not a full match, there's a 50% chance they'll be a half matched, which is considered a haploidentical. 25% of the time, your sibling will not be a match at all. Now, parents and children are always half matched unless you used a donor egg or donor sperm. Then that doesn't work. That logic won't work anymore. But you always will have a half match, so many a haploidentical, and this is why we're able to really extend transplant out to more than just the people who have a matched sibling or even a matched unrelated. Now we can do more mismatched and even half matched, and it seems to work pretty well. So what is a selection of donors? So fully matched is ideal, I think, in this. Maybe the sibling, maybe not. I think one of the caveats there is we know that younger donors are better. And so a lot of times if you take the average person with myelofibrosis, they might be in their 60s, their donor might be 70. I usually will probably err on the side of using a matched unrelated donor who's 22 versus a matched related donor who's 71. We do know that the age of stem cells is incredibly important, so that donor age is critical. It usually starts to, it sort of becomes worse around age 26, and about every decade of life, the outcomes become a little bit worse. Minimally so if you say, oh my God, all I have is a 50-year-old donor. Hey, if that's all you have and they're matched, that's good, take it. We still have very good outcomes even with older donors, but when we're optimizing everything, when we have the luxury of optimizing who we can use, that's something that comes into play. We can use a mismatched or unrelated donor. There was some earlier data that suggested that a mismatched donor, which is 9 out of 10 or 7 out of 8, would potentially be a little bit more high risk. I think we've been able to overcome some of those caveats. And then haploidentical, which is half matched. That means the half from mom may be matched, the half from dad didn't, or it's a child. And people say, well, I have a child, should we type them? Well, I know they're gonna match you because half of your DNA went into that person. However, sometimes the patient themselves, so you might say, okay, I have this son, he's gonna be perfect, but as the patient, you actually have antibodies against him. And so that immunity against your child, which is much more common for mothers and children because they carry the baby inside of them and can develop immunity against the HLA that comes from dad. There is that possibility that you can do that, have that immunity and not be able to use them. But fortunately, we've managed to improve our transplant practices so we can use a lot of donors. What to do with a large spleen? That's the end-old question that nobody has a good answer to. Now in the era of JAK inhibitors, we often are able to shrink it down with JAK inhibitors, and that's ideal. Splenectomy is something you have to be incredibly careful about weighing the risk benefits. It's not something we routinely or frequently do anymore. And then splenic irradiation can also be done before transplant. Conditioning regimens, and these are all terms that you hear about, and the conditioning regimen is a chemotherapy that you get before the transplant. And when you get a transplant, you really get at most like a week of chemotherapy. There are some regimens that maybe give you chemo 13 days before and then give you chemo that week before, but ultimately you're just getting one round of chemotherapy before you get those cells. And as I mentioned, there's the myeloablative, which is where you knock out every cell and you wouldn't recover. There's a reduced intensity, which is where you give some disease-directed activity, but it's not as intense because intensive myeloablative chemotherapy is very toxic. And then there's non-myeloablative, which all we're doing is suppressing your immune system so that the donor immune system can get in. And everybody has a different take on whether you should use myeloablative, reduced intensity. Whatever your center does and is comfortable doing is what you should do. Because again, there's lots of different studies that show benefit or risk to certain conditioning regimens. Some people say you must get myeloablative, this is clearly better. Other times, they say, oh no, but reduced intensity is pretty good too. And I think our data for that is not fantastic. So that is really a discussion to have with a transplant physician and not something I can tell you, oh, this is the regimen you should use. So GVHD, so what graft versus host disease is it is that new immune system. I want it to attack the bad cells. Sometimes it goes in and gets the good cells, so it gets your skin, your liver, your intestines. It can affect almost any organ system. And when we talk about graft versus host disease, we kind of rate it. Now, when I ask people, what's your biggest fear of transplant, I often get graft versus host disease. And very honestly, graft versus host disease is something that can be very bad. We've gotten a lot better at it, and I'll tell you why when I go over some of these drugs in this slide. But it can be something that's very bad, but it's also something that in the majority of people is treated and can get better. So it's very infrequently a life-ending thing. But it can affect quality of life quite a bit. I think disease relapse is the thing people should be most scared of because the disease can come back, and we'll talk about that a little bit later. So we use chemotherapy after the stem cells to prevent graft versus host disease. The goal of that chemo is to actually knock out the cells that would cause graft versus host disease. Historically, we used to use methotrexate, and then we used something called tacrolimus, which is a medicine to suppress the immune system. It's something that's used frequently. The tacrolimus, cyclosporin, et cetera, they're used in organ transplant. But cyclophosphamide is, cyclophosphamide is now what we are using. Now, cyclophosphamide is another type of chemotherapy, and wait, you're probably going to say, wait a second, why are you giving my nice new fresh stem cells chemotherapy? Like, don't you want them to be really good and grow? This chemotherapy is pretty interesting because it actually gets kicked out of stem cells, and so it only goes after the cells that are dividing and are going to cause graft versus host disease. And what we've found is we've been able to reduce the risk of graft versus host disease by almost 20% by using post-transplant cyclophosphamide. The other thing that post-transplant cyclophosphamide has allowed us to do is use much more mismatched donors. So we've been able to really balance out the different donor types that are there, the half-matched, the 9 out of 10s, the matched unrelated, the matched related, and get extremely similar outcomes because we have post-transplant Cy. So this has really equalized the donor question. It also makes it more challenging because then you're like, well, geez, if all these donors are equal, do I go after the younger donor? And it becomes really difficult for somebody who most of their transplant career says a half-matched is really high risk to being like, oh, I'm going to use a half-matched instead of using a fully matched donor. But we've started to do that sometimes, especially if the matched donor is much older. There are other interventions that some centers use. Again, I'm a huge proponent of post-transplant cyclophosphamide. Use of CD34 selection is used at very good centers. Some places still use methotrexate and tacrolimus. I certainly, it's not something that you should go in and say, oh, well, I want this GVHD prevention. Again, transplant centers all kind of do different things, and you want to make sure you're doing what they are most familiar with, because that's what they're best at. So when we talk about GVHD, acute GVHD typically involves the skin, the liver, the intestines. Chronic can be almost any organ system in the body. It occurs in about 30% of transplant recipients. So when I started doing these talks for patients, I used to have people like stand up and stuff. Maybe I should actually do that, because everyone probably has the postprandial comatose. So why don't we go and do that? So everyone stand up. All right. What I used to say is this half of the room sit down. So sit down. And then I'd say, okay, these are the people who have graft versus host disease. Now, about halfway through this little section right here, this half sit down. Now, this is the amount of people that have graft versus host disease. You two in the maroon. This is the group that would have graft versus host disease. Now, everyone but this row sit down. It's like those 4 people right there on the edge. Those are the people who have significant graft versus host disease that becomes really debilitating and life-changing. Okay, now everyone can sit down. I guess if you want to stand up, you can go in the back and stand up. I won't be offended. But that's just to give an idea of like how many people get graft versus host disease. And it is a treatable thing. And we've been finding with post-transplant cyclophosphamide, even when we see it, very severe graft versus host disease, we often see the skin, which is far more treatable and far less debilitating to people than the gut graft versus host disease. When you have GVHD of the intestines, it can often have lots of diarrhea. People can't eat, they lose weight, and it can become a much more clinically significant and harder to treat disease. All right, and why do we have graft versus host disease? Well, unfortunately, we can't break them apart. Graft versus host disease is the yang to the yin of graft versus myelofibrosis. We want that new immune system to go and fight those myelofibrosis cells that are left behind. That's critical. But if we have graft versus host disease, we can't unfortunately separate it. People have been trying for decades. I remember when I was a fellow, they were like, oh, let's separate out this type of T cell and this will fix it, and then we'll get graft versus leukemia without graft versus host. But nobody's been able to really make it stick. I think the post-transplant side has really changed things, though, which is good. So infections. The biggest infection, so when you're in the hospital and you're neutropenic, the biggest problem is yourself. I mean, we all have loads of bacteria. We have loads of bacteria in our intestines, in our mouth. Our mouths are really bad. The intestines have a ton. We actually have more bacteria cells in our body than we do human cells. So those bacteria can cause problems when you're neutropenic, meaning your white blood cell or the neutrophils, which are your first go-to for fighting infection, if they're really low. Now, after your blood counts recover, you might get out and you say, look, I have neutrophils, my blood counts look really good. Why am I immunosuppressed now? Well, you have to remember we put a brand new immune system in there. So just think of it. Right now, all of us have lived however long we've lived. And our immune system for this entire time has been learning. All of those sort of mechanisms that Dr. Nangalia talked about creating diversity in the immune system are made so that we are able to go after multiple different types of bacteria and viruses. And, it's like when you put a kid in school, they get sick every week. And that's because they haven't learned all this. But as they go on through school, they are not sick every week. They become sick hopefully once or twice a year. And that's because the immune system learns. Well, all of that learned immunity is gone. And so even if your counts look great, you still have to relearn a lot of stuff. God, this thing is super sensitive. Your immune system still has to learn so much extra about fighting off different infections and diseases and stuff like that. So that's why we kind of invoke the COVID restrictions. Have your small pot of people that you meet, wear masks, don't go in crowds. You just have to be really careful. The other thing you have to be careful is foodborne illnesses. So, you can't have undercooked meats. I don't want people to get salads from salad bars or go to buffets, all of those things, because you're much more susceptible to foodborne illness. And then there are also other things with prolonged immunosuppression, different types of fungal infections. In Arizona, valley fever is the big one we worry about, which is an endemic fungal infection here. But depending on where you're at, there's always some endemic fungal infection that can get you. So what do we monitor after transplant? So first is some chimerism and chimerism, I've heard all sorts of stuff, but chimerism is kind of how we refer to it. And what this tells me is how many cells are donor, how many cells are recipient. Ideally, you want the cells all to be donor that you check. This is in your blood, though. Your skin cells won't change, your liver cells won't change, your hair follicle cells won't change. If you're going to commit a crime, leave behind your blood and not your hair follicles, because they can identify you still with your hair follicles, but not your blood. And that's something. Now, the chimerism can be done. We sometimes select out different types of cells to understand. So there's CD33. This represents all those myeloid cells, neutrophils, monocytes, all the things that generally are implicated, and that cell line is implicated in myelofibrosis. And then there's CD3. These are the T cells. They can cause graft versus host disease and graft versus myelofibrosis. One of the things that we watch for after transplant for relapse is we actually watch the chimerism. Now, many people will not get their CD3 up to 100%. It can take a while. And that doesn't, as long as it's heading in the right direction, that really isn't that big of a deal. The CD33, though, is one we really pay attention to, because the CD33, if that's starting to show up again, that might be your disease cell. So that is something that's important. So when somebody says, oh, your chimerisms look good, they're both 100%, then you can, that's good. It's not perfect, but at least it's nice. But if they say, oh, your CD33 is a little low, that could be a sign of the disease starting to come back. Now, there are interventions we can do for that to help try to slow that process or prevent it and make that go back to 100%. But that is something that we do watch after transplant. So what do we expect for our labs after transplant? First of all, they are very slow to recover. So, I have a leukemia patient sitting next to a myelofibrosis patient, and the leukemia patient's labs are going to recover a lot faster because they have normal marrow that it's going into and not this big desert. I mean, it's kind of like planting a garden in a desert outside, which for those of us who live in Arizona, it's just not a pleasant experience and doesn't work so well. It does take a long time for those counts to recover. And I mean, I even have people who are 6 months, a year out whose platelets are still less than 100. And I don't worry too much as long as, they're 100% donor. There can be different organ dysfunction. A lot of the medicines we use for graft versus host disease prevention, et cetera, can affect the kidneys and the liver. So we watch those numbers carefully, and people always come in and say, oh, your liver looks this today, your kidneys look this today. This is going to be a very fluctuating thing. And another thing also that to note is when people who have myelofibrosis get a bone marrow biopsy, they will still have fibrosis. So with all these new access to record things, which I think in general is a good concept, but in practice can sometimes really backfire. When you look at your bone marrow, they're still going to say there's myelofibrosis in it. That does not mean you still have the disease. It just means that scar tissue takes a very long time to go away. It can take up to 2 years. And that doesn't necessarily have any implication on your expected outcome. It just tells, is part of the process of getting rid of fibrosis is hard to do. It's just like a scar. If you think of having a scar on your arm, it takes a super long time for that scar to limit itself down to a tiny little sliver. For a long time, you might have a big scar. So survivorship is super important because you need to make sure you stay healthy after transplant. And then relapse. So this is a thing that nobody likes to think about or talk about, but we have to consider. So when we talk about relapse in myelofibrosis, as a transplanter, I say, well, geez, it's usually lower in myelofibrosis than it is in AML and MDS. So I actually don't, and it's all perspective. But it is a serious thing because you go through this whole transplant, and then sometimes the disease can still come back, and that's hard. That's mentally very challenging, physically very challenging. But there's a lot of ways that we monitor this, and this is an important differentiation. Molecular relapse is decrease in chimerism. How much is you, how much is donor? Recurrence of driver mutation. There's a really great study that just came out in the New England Journal of Medicine that looked at presence or absence of the driver mutation at different time points after transplant, day 30, day 100, day 180. Now, even if you did still have it at day 30 or day 180, that doesn't mean you have a 100% chance of relapse. But it does tell us that the chances of relapse are higher. Now, right now, we don't know what to do with that information. especially day 30. I'm not going to start taking away all your immunosuppression or you're going to get graft versus host disease. So it does provide a challenge, and I think we look for all this stuff and we identify it, but it's very hard to know what to do, and it's very hard to tell patients what this means because it is very kind of more cerebral type topics. But it is important that if somebody is looking at the driver mutation and looking at the chimerism, if you see it being off, that doesn't necessarily mean you're absolutely going to relapse, but it does probably mean you need to do some type of intervention and talk to your transplant doctor about what possibilities may be there. So that's molecular relapse. Usually in that point, the blood counts are very stable. The bone marrow doesn't have the atypical megakaryocytes and some of those other changes we expect with myelofibrosis. Overt relapse is not only a decrease in chimerism and recurrence of the driver mutation, but you actually see the abnormal cells in the marrow. The white blood cell count starts going up. We start to see some of those changes that are more consistent with myelofibrosis. But these two, molecular relapse, there is some data that suggests if you give somebody like more cells from the donor or do something, that you may be able to reverse that. And so again, what do? We can give donor cells, donor lymphocyte infusion, and what's the trigger to do that and when to do that is a fairly complicated topic depending on how your post-transplant course is going. Now, in the setting of overt relapse that we weren't able to overcome, what's interesting is people come back sometimes in an earlier stage in their disease. So for example, I have a patient who had PV that went to myelofibrosis. When it relapsed, it came back as PV. And so we started to treat the PV. So in some cases, when somebody's relapsed, they relapse early enough in the disease that we actually just monitor them, especially if we're not able to overcome it with our different interventions. And that doesn't necessarily mean you have pending death in the next 3 months. It means that we're basically, unfortunately, back to where we started, but it is something that we kind of continue to monitor. I had one patient who was transplanted, had recurrence of her JAK2. 10 years later, I did her second transplant. And now I think she's a few years out and doing well. But it can be a very different time course. So this is something that, again, we know to watch for these things, we look for them, but it doesn't, I think how to clinically manage them is very individualized. So in summary, bone marrow transplant is a curative option for myelofibrosis. It's one that everyone who has myelofibrosis and is within an age to transplant should at least talk to a transplant physician to get the information. When to go under transplant is still under investigation, but be sure you really want to go to transplant before you think you need one. So some people say, oh, I'm waiting for the last minute. I'll wait till I'm really sick. That is not when you want to go to transplant because then your outcomes will be worse. And then know your risk, like understand what the different factors are that are contributing to your risk. It's a very complex process. Take your time digesting everything. And even post-transplant variables, everything, there's so many caveats. That's why it's very hard to put a talk up that is sort of like, this is what you do X, Y, and Z, because what we might do for one person is very dependent on have they had any infections, what type of graft versus host disease have they had, what other things are going on. And so again, it's something that's why it's so important to trust your transplant center and trust your transplant doctor, because these decisions are not something that can easily just be like check, check, check. You're gonna have a BMT nurse coordinator. They are going to be your best friend. Be nice to them. They really help an enormous amount and are really knowledgeable. And write down your questions. People leave the room after I talk to them, and I know I can tell their eyes are like, deer in headlights. Go back and write your questions, because the next time you come and see me, you're gonna forget them. And so it's very, very important to have your questions written down. That actually applies for everything, not just transplant. And then again, decisions such as donor choice, conditioning regimens, GVHD, all of us may have a slightly different take on it based on our experience. I think the data is very scattered in terms of what type of conditioning regimen, what type of donor we should use, GVHD prophylaxis. So that is something that I certainly don't want to be prescriptive about. Again, another point to make sure you trust your transplant center, because this is something that, very honestly probably doesn't have the biggest impact on your outcome, but is something that you have to feel comfortable that your transplant doctor is giving you the right thing. All right, and that is the end of this talk, and then we probably need a couple more jokes because this is really a depressing one.